so they are age controlled. So that is why I really want to set up that big, try and maintain populations in the lab, but trying to keep the natural gut microbiota so that such work can be done. So I didn't do work on the Plasmodium itself, as in infecting it and seeing whether it has the bacteria has an effect on that or any of my experiments. That's what I intend to do.
Okay, so let's give a big round of applause. Thank you. And I will take my seat for a while and hand over to my co-chair, who will take you through the next presentations. You clap for me for the work I did.
Thank you very much, Dr. Osweji. Okay, so we move on to the last three presentations. So the next on the list is Samuel Oforiado. And I think we are running slightly late, so I'm going to keep to my co-chair's principle.
Good afternoon. I'm Samuel Oforiado, presenting on the topic genotyping and drug susceptibility testing of mycobacterial isolates from a population-based tuberculosis prevalence survey in Ghana. My supervisors are Prof. Kwesiado and Dr. Lydia Mosi. I think from yesterday and today, the two earlier presenters on TB have given some statistics, so I don't want to bother you much. But what I want to talk about is that these are notification data which are presented to WHO by individual countries' NTPs, that's the tuberculosis control programs. And especially in Africa and Southeast Asia, where the burden of the TB disease is very severe, where the burden of disease is very severe, the notification data is not always complete because they do not cover the whole country, or the surveillance is very weak due to some logistical problems these countries have. So to determine the true burden of TB at national and global levels, Ghana was one of the 22 TB-focused countries earmarked by WHO to conduct a population-based prevalence survey to determine the true measurement and the true burden of TB through a direct measurement of the disease. So this is a TB prevalence survey. Ghana conducted its prevalence survey in 2013, and this was a community-based survey whereby the sampling was by proportion to population based on the 2010 national population and housing census. So it was based on symptom screening, then chest X-ray. So if you have symptoms of TB, that's coughing for more than 2 weeks, night sweatness, then you have abnormal chest X-ray, you are eligible to produce sputum for sputum sphere microscopy and also for culture. And for this, we use both the midget, that's the liquid culture, and the solid culture, that's the LG. And we went on ahead to also use the gene expert to confirm all the microscopy positive cases, to confirm, because the microscopy only determines whether it is an acid-fast bacilli, but it couldn't differentiate between the bacilli that causes TB, which is known as is a group of organisms, related organisms known as the Mycobacterium tuberculosis complex, and also the non-tuberculous mycobacteria. So that forms the basis for this work. Having determined the prevalence of TB through the population survey, we went ahead. We wanted to find out, because the isolates, the MTB isolates, even though they are related genetically, genetically, they also have differences in their host susceptibilities and also differences in their DST patterns and also in their pathogenesis. So we wanted to find out what the types of species that we isolated, and also go ahead to differentiate between the NTBC, that's the complex that causes true TB disease, and the non-tuberculous mycobacteria. So that was the rationale for the study. But I want to say that the current methods that are used by microscopy and phenotypic identification are laborious, and also they have low sensitivities. So there's the introduction of line probe assays, which are more rapid and also very sensitive, was what was used for this study for the differentiation and also the DST patterns for the isolates that we had through the prevalence survey. So the aim of the study was to use line probe assays to differentiate and determine the drug susceptibility testing of patterns of the mycobacterial isolates we had from the prevalence survey. And also my specific objectives were to speciate among the members of the Mycobacterium tuberculosis complex, also to speciate among the non-tuberculous Mycobacterium, and also to determine the rifampicin and isoniazid resistance profile and associated mutations using the genotype MTBDR+. This is a line probe assay kit from Heinlein Science from Germany. So these were stored isolates. So we stored the isolates, they were kept in -80. Then we extracted the DNA, did a multiplex PCR. This PCR kit, the primers came together with the kit that we use for the differentiation. It's a multiplex primers and multiplex PCR that we did. Then after that, the MTB complex, we use the genotype MTBC to do the differentiation among the complex. Then we use the genotype CMAS for the NTM. Then after that, for the complex, which causes the true TB disease, we use the genotype MTBDR+ for isoniazid and rifampicin resistance. All the methods were the same. They follow the same, all the kits has the same assay procedure, but the only difference among them are the types of probes that are used. So for the speciation, the kit is able to differentiate among the tuberculosis complex organisms. So we had, out of 165 MTBC isolates, we had 161 being M. tuberculosis. Then we have 4 of them being M. africanum. Then there was no bovis. The kit is able to differentiate between bovis and its subspecies. But in this case, we didn't find any bovis. However, what was interesting was that for the africanum, even though we expected more from this because these samples were from Ghana, which is in West Africa, and we know that M. africanum is very very prevalent in West Africa. So low isolation of M. africanum was a bit compared to previous studies. But however, what we thought was that studies in Senegal by Diop et al. Has also found that M. africanum, even though M. africanum has regional variations, there are a lot of regional variations in M. africanum isolation, even in endemic countries. So it's possible that even though previous studies have a rate of about 17 to 20%, there are other studies also in Ghana here that shows 4% and 6%. So the second reason could also be that even though our samples were from a nationwide representative way, it's possible that our sample number is also relatively small compared to the other previous studies. So if we had more isolate, it could have been, the isolation rate could have gone higher or remained the same. Also with the NTMs, we isolated about 14 different types of NTMs. And we realized that M. fortuitum and M. intracellulare were the highest of them. And this is because M. fortuitum is very common from other studies that has been shown. M. fortuitum is very common isolated because they are very ubiquitous. Even in potable water, they are found in them. So, and these were from sputum samples that are coughed out through the mouth. So it's possible that through the drinking and other things that we take in could be the reason why we had a lot of the M42 isolated and also the M intracellulare. However, the kit couldn't identify some of the samples to the barest, to the species level. For the DST, we realized that about 18 of the isolates were resistant to isoniazid only. That's also known as isoniazid monoresistance. Then 2 of them were resistant to rifampicin only. Then 11 were multi-drug resistant, that is resistant to both isoniazid and rifampicin. And as expected, majority of them, over 80% of them, were susceptible to these 2 drugs, isoniazid and rifampicin, because these are the 2 most potent drugs or anti-TB drugs in the first-line drug regimen for TB treatment. This table here shows the probes that were used for the MTBC isolates that were used for this. And it was realized that majority of the rifampicin mutation were in codon 516 of the RPOB gene. Then for the isoniazid, we had mutations in both the CAT-G and the INH promoter region. So to conclude, say that most of the M. tuberculosis is the dominant species of the MTBC causing TB in Ghana. M. fortuitum is the most frequently isolated NTM from sputum samples. Then majority of the isoniazid resistance were in the codon 315, that's from serine to change from serine to threonine, and for the rifampicin were in codon 516. The MDR rate was 6.7%, and from this study, we can conclude that the genotype mycobacteria series is an appropriate tool for speciation of mycobacteria isolates and screening for MDR-TB in Ghana. I recommend that the HIV status of survey participants must be determined in subsequent TB prevalence surveys, because this particular one, we didn't do it. And also because some of the NTM species couldn't be identified by this case, which suggests that sequencing should be done if possible in cases where the LPA becomes exhaustive. And also we should conduct a study to determine the DST profile of isolated NTM of clinical importance. And also there should be a national policy on diagnosis and treatment of MTM disease. Currently, we don't have anything like that. I want to acknowledge the polymer supervisors and also Afrique One and WACBIC for paying my tuition, and Ghana Health Service through the NTP for funding their research. Thank you.
Thank you very much. That is right on time. So we have time for 2 or 3 questions, and they have to be very short and straight to the point. Yes.
Yeah, so I heard you mention GeneSpec, that you used it. At what stage did you use it?
Yes, we use it in the course of the survey. In the course of the survey, we were to also, those who were positive for MTBC through microscopy. We wanted to confirm because they were to be put on drug treatment and wanted to know whether the AFB that was identified by microscopy was truly MTBC or NTM. Because if it's NTM, you can't treat it with the standard TB drugs. So the GeneSpec is able to differentiate between MTBC and NTM.
Okay, time for one more if there is. Otherwise, I would say join me in thanking Samuel for his nice presentation. Then we move on quickly to the next. Ruben, are you or Johnny? Okay.
Good afternoon and thank you. So my name is Ruben and I'm presenting small work we did to evaluate the diagnostic methods for malaria in the Volta, four hospitals in the Volta region. Professor Wandari is my supervisor. Dr. Dinko is also supervisor of mine. So I'm sure we've heard it, that some level of reduction in the burden of malaria has been achieved. But there is still a problem, because if you come to Ghana and in our region, and especially in the Volta region, it is still a problem because it accounts for about 40% of OPD cases. And then out of this, 60% of them are children under 5 years or are pregnant women. It is recommended that you diagnose that someone has malaria before you treat, because it improves the general management of the person with the illness, and also helps to reduce the possibility of the emergence of drug resistance and its spread. So in Ghana, or over the world, microscopy is a standard point of care diagnostic tool that is used, where you use a Giemsa stain to do the blood film. But it has limitations in sensitivity and specificity, largely based on the staining technique and the individual who is evaluating the slides. So WHO some time past recommended the use of rapid diagnostic tests, which are quick and they are specific to the pathogen that you are looking for. But its limitation, the one advantage is that you can use it in a very resource-limited setting where you don't have microscopes. You can use it to diagnose malaria. But its limitation is that it only detects, what we have in our hospitals now only detects falciparum, but there could be other parasites as well. So molecular diagnostics add an additional advantage because they are highly sensitive, highly specific, and when it comes to the diagnosis of malaria, it provides the opportunity for you to see which species of the Plasmodium is actually present in the blood. So one problem we are facing is presumptive treatment in our hospitals, where clinicians treat the prescribed drugs based on the clinical symptoms that the patients tell them they have. Now, this results in overtreatment and an inappropriate administration of anti-malaria drugs. And it's also uneconomical because the drugs that you could have used to give to somebody who actually has malaria, you give it to somebody who doesn't have it. So it's a waste of money. So what we decided to do as a background research for some of the things we wanted to do later, we wanted to investigate the reliability of these diagnostic tools, the blood film and then the RDT in the 4 hospitals that we selected, and then use PCR as a gold standard to compare their specificity and sensitivity to them. So for the PCR, we also took the opportunity to actually find out which species have actually infected the people who come to the hospital. So we use the whole polyclinic, whole municipal hospital, the whole Volta Regional Hospital, which is a referral or tertiary level hospital, and then the Hohoi Municipal Hospital. Individuals of varied ages who have come to the hospital and the doctor suspects that they have malaria and has actually written a request for them to come to the lab to do a test for malaria. They are the people we recruited to join. So if they had these symptoms and they also had a request from the doctor to do the test, we talk to them. If they consent, then recruit them into the study. So we just pick a finger, we do a finger prick and then take blood from it. Some of the blood is used for the blood film, some is used for the RDT, and then we take a blood spot on a filter paper for the PCR. So what we did was that we didn't interfere in the experiment to determine whether they were RDT positive or blood film positive. We left it to the hospitals to do it themselves, and then we take the results. So we took the filter papers and did the PCRs on them. So in all, we had about 211 participants, and out of that, about 92% of them had a symptom. They complained of the symptoms that we were looking for, that they had fever, maybe high temperature, headache, body ache, and all that. So you will notice that in the whole polyclinic, which is more like a primary level of a clinic, there were 71 people who came. And in the next slide, you realize that what they do there is just the RDT. It's just a one-man manned lab. So they just do the RDT. And this person reported that all the 71 people who did the RDT were positive. Now, if you compare it to PCR, you realize that it was only, it's just a few, only about 60% of them that were actually positive for malaria. Now, I want to refer you to the results from the Volta Regional Hospital. This is a tertiary level hospital where you have really trained microscopists who can actually evaluate the slides. And you see that the same number of blood films that were positive were also PCR positive. The RDT was, prevalence was lower than that of the PCRs. So in total, for the blood film, all the samples, those who were actually, they requested for blood film, 21% of them were reported to be positive. Now, if you did a PCR, you realize that the percentage was lower. So in general, for RDTs, 57% of them were positive for the RDT. These are data from the hospitals themselves. So if you compare it to the PCR results, you realize that more than 60% were actually malaria negative. Now, one thing we found out was that in at least one of the hospitals that we did the work, the people were coming to the lab with a lab request to do malaria test, but they already had prescription for anti-malarials. Okay, so 24 out of the 24 cases that were positive for blood film, we realized that more than 50% of them were actually negative by PCR. And then for those that were reported to be blood film negative, out of the 94, 17 of them were actually positive. Okay, so you can see we are either telling somebody he has malaria when they don't have it, or we are saying it's negative when it's positive. So for the RDT, those that were positive were 94, but it's only 53 of them that were positive by PCR. And then those that were negative, we found 7 of them to be positive as well. So we did a sensitivity and specificity calculations, and we realized that RDT seems to be more sensitive and specific than the blood film when you compare both of them separately to PCR. So this again goes to tell you how high the prevalence when you use RDT is compared to PCR. Now, we also found out that the way these RDTs are actually stored, some of them are below standard. Okay, and then you doubt where some of these RDTs are gotten from. Okay, so for some, we're actually looking for the batch numbers and all those ones, we couldn't find them. So poor conditions and then poor quality of the RDTs could also have contributed. But one thing I must state is that most of the people who come to the hospital and they are suspected to have malaria, before they come, might have taken an anti-malaria already. So it is possible that they were infected, but the anti-malaria they have taken is actually reducing what the RDT is seeing. But PCR can be able to pick it up because the parasite DNA might still be present. So we found out that 5 out of the 211 cases that we had malaria, P. malaria in there. So we have 1 monoinfection of P. malaria and then 4 mixed infection of falciparum and P. malaria. So the conclusions we came to is that we are actually over-diagnosing the malaria based on the techniques we are using. And then the RDT seems to be more reliable than the blood film. But as I have mentioned, these things are the quality of the kits and the storage conditions can actually affect their function. So I want to thank the staff, the laboratory staff of all this clinic, and then especially Felix Ansa, who helped us find things in the lab when we were doing the PCR in Dr. Wandari's lab. Thank you very much.
Thank you very much for keeping to your promise. So he said that's 2 minutes. Okay. I see a lot of hands up already.
Yeah, very simple question.
Yes.
Would you recommend PCR for routine diagnosis of malaria?
Well, apart from its cost, it would have been the best. But we
But I'm concerned subclinical. PCR is very sensitive.
yes.
So when you have subclinical dose of parasite,
Okay.
you may not have malaria, but
Yeah. So that is a confounding factor you have to consider.
Related to our gentleman's question here,
Yes.
in South America where the parasitemia is a lot lower, one of the things that they find is when you have a fever, you can actually see that microscopically most of the time.
Okay.
However, when you're carrying around malaria and they look with PCR, right, and you're afebrile, that's an index that they use in places like Brazil, Peru, etc. And the reason that that may be important is because those individuals that have those very low levels can very likely transmit what you're not seeing.
Yeah.
And so, just a follow-up to that.
What is the detection limit? What is the dynamic range? Because if you are talking about yeah, that's right. Because if you are you know the dynamic range or the detection limit
Of the RDT?
PCR versus RDT.
Okay, so PCR is highly sensitive than RDT.
Sensitivity
Yes.
doesn't correlate to the detection limit.
Okay.
If you are going to compare RDT
Yes.
with PCR, the first question that you have to answer is to get the detection limit of these two techniques.
Okay.
That's the first thing you have to do.
Okay.
Then once you get the detection limit, you look at the dynamic range before you conclude.
Okay. All right. Thank you.
Yeah, Ruben, so you concluded by saying that RDT more sensitive than microscopy,
More reliable.
more reliable.
Yes.
Okay. So what specific antigen of the parasites were you actually looking at?
Okay. So this was the histidine-rich protein antigen.
So when the person has cleared the